Thank you so much. And as Matt mentioned, my name is Amy Gaviglio. I am a genetic counselor by training and have served in the Minnesota Newborn Screening Program as their follow-up coordinator for the past 12 years. So with that, we will get started, and I need to start with this first slide by indicating that the following module will provide an overview of newborn screening in the United States. And as Matt mentioned, the creation of this module is funded through the Health Resources and Services Administration of the U.S. Department of Health and Human Services. And so we do have 3 learning objectives for this module. The first objective is to understand the current state of newborn screening processes in the U.S. and recognize that variations do exist between individual state screening programs. The second is to appreciate the differences
is now joining
between screening and diagnostic tests. And the third is to identify resources related to newborn screening geared towards both healthcare providers as well as patients and families. Next slide. So we really felt it was important for us to begin the module by clarifying that when we talk about newborn screening, that the totality of that concept of newborn screening is actually made up of 3 distinct types of screens. So there's the blood spot portion, which I think what most people think of when they think of newborn screening. But there's also 2 point-of-care screening components, the hearing screening, as well as the use of pulse oximetry to detect critical congenital heart disease. And while the focus of this and the following 2 modules in this series are really largely on the blood spot screening segment,
Elizabeth Bertman
is now joining.
Both hearing and pulse oximetry screening will be touched on briefly later in this module. Next slide, please. Perfect, thank you. So this slide presents 4 key points that serve as just a very brief background on newborn screening programs. And the first is that newborn screening programs are considered true public health programs, in that the screen is offered to all newborns in the United States and is often overseen by the state's Department of Health. Robust newborn screening programs, however, do rely on the knowledge of numerous stakeholders, especially primary care providers, in order to successfully meet the goal of identifying and treating affected infants as soon as possible. Additionally, each state actually governs its own newborn screening programs, so they are state-based programs. And what this means is that variations do exist from state to state, and healthcare providers, especially those that practice maybe on the border of states, should become familiar with the screening processes in the state or surrounding states in which they practice. The third is that newborn screening programs are also considered opt-out programs in nearly all states. And so this means that the default is for newborn screening to occur, and this happens without kind of overt informed consent, but that parents do have the option to refuse or quote-unquote opt-out of receiving screening on their child's behalf. And the fourth is really, I think, one of the key tenets of newborn screening, and that is that the disorders that are screened for by newborn screening programs must meet certain criteria, including and perhaps most critically, that the disorder has an effective treatment available. Next slide. So James Wilson and Gunnar Jugner first proposed criteria for population screening in a report commissioned by the World Health Organization in 1968. Interestingly, this report came out shortly after newborn screening actually started. So newborn screening for PKU started around the same time, a little bit before, and was really starting to take hold around the time of this report. And though it's been over 50 years since this publication and over 50 years since the advent of newborn screening for PKU, the criteria suggested by this report and by Wilson and Jugner are still very much used today to assess conditions for inclusion on newborn screening panels, as well as for other population-based screening initiatives. Next slide. So the 10 criteria in the World Health are listed here. So to summarize, obviously I'm not going to go through all of these, but in order for a disorder to be considered appropriate for population-based screening, the disorder should be, of course, of clear medical consequence and have an effective treatment. Additionally, diagnostic and treatment centers should be available. The natural history of the disorder should be fairly well understood and should have a recognizable latent stage. From a screening perspective, a suitable test should exist that allows detection of
Elizabeth Burtman
is now exiting.
And the cost of the screening program should be analyzed. Next slide. So we've talked really briefly about the criteria that disorders must meet for inclusion in population-based screening, but here we want to talk a little bit more about the characteristics of screening tests in general and how they compare and contrast to diagnostic tests. So this table shows some key differences between screening and diagnostic tests. As you can see, screening tests are typically offered to a large non-symptomatic or asymptomatic population, and thus are really only able to provide an estimate of the level of risk an individual has of being affected. So that means that a positive or abnormal screening result will indicate essentially whether a diagnostic test is subsequently needed. Because screening tests are trying to identify individuals at risk of a serious but treatable disorder, the focus is more on the sensitivity of the test. That is, we really want to try to identify all truly affected individuals, but to do so, that means that the specificity of the screening is usually lower. So a proportion of individuals with a positive screen will ultimately be found to be unaffected, and the test result will be considered a false positive. So in essence, in trying to ensure we pick everyone up, we do sacrifice that there are false positives in screening results. If we contrast that to diagnostic tests, those tests are really aimed at a targeted population where there is already some indication of the presence or risk of a disease. So this could be through clinical symptoms or by a positive screening test. So the purpose of a diagnostic test is different and is to provide a more or less definitive diagnosis, which means that diagnostic tests have higher specificity than screening tests. You're not going to see as many false positives with diagnostic testing. False negatives are also lower typically with diagnostic testing because they're really used to more accurately identify those truly with and without the disease. Next slide. All right. So I'm going to kind of go back in history a little bit and talk a little bit about PKU. So after newborn screening for PKU became established in the early 1960s, newborn screening programs continued kind of a slow but constant expansion of their screening panels by adding conditions such as congenital hypothyroidism, galactosemia, and sickle cell disease. And what that means is that by the end of the 1990s, newborn screening programs were screening for about a handful of disorders. However, if we kind of fast forward to the early 2000s, expansion of newborn screening programs really hit a boom. And this was because of the introduction of tandem mass spectrometry that allowed programs to multiplex their testing and screen for a number of disorders using the same small blood spot. And while the application of this new technology led to the ability to screen for many more disorders both quickly and cheaply, it also led to wide-ranging disparities between state programs in terms of particularly how many different disorders were being screened from state to state. So in 2006, in an effort to provide uniformity to state programs, the American College of Medical Genetics, along with the Health Resources and Services Administration, identified a list of disorders for which they recommended that all state programs should be screening for. This group also outlined a process of standardization and evaluation guidelines for future additions to state screening panels. So this list of disorders that the ACMG and HRSA put together is known as the Recommended Uniform Screening Panel, or more commonly the RUSP. So I really want to point out here that the R in the RUSP stands for recommended and not required, which means that even though this goes through this federal process, and the disorder is recommended to be added, each state program still does independently choose whether they will screen for the disorder or not. Typically, disorders are added to their RUSP after thoughtful consideration of a host of criteria, largely based on the previously mentioned Wilson and Youngner criteria. Next slide. So this slide actually illustrates the steps needed for a disorder to be included on the RUSP. And so to begin, a disorder must be kind of quote unquote nominated and a nomination package submitted. And this nomination package includes but is not limited to information on the natural history of the disorder, treatment effectiveness, and the availability of a suitable screening test. Once that nomination package is received, it is then sent to a work group called the Nomination and Prioritization Work Group. And this group assesses whether the disorder seems to meet the screening criteria that we've discussed earlier on. They will then present that to the full committee, and the full committee will vote to continue the process based on the review of the Nomination and Prioritization Work Group. If they do vote to move it on, the disorder then moves to a larger scale evidence review work group. And so this evidence review work group does a thorough literature search of the disorder and conducts interviews with disorder-specific and public health experts. The evidence review work group is given 9 months to complete their analysis and present their findings back to the full committee. The full committee at this time votes on whether or not they will recommend the disorder for inclusion on their RUSP. If they do vote yes, the full committee's recommendation for inclusion to the RUSP is sent to the Secretary of Health and Human Services, and he or she ultimately has the authority to add the disorder or not to the RUSP, and the Secretary is given 180 days to make this final determination. So you can see it's quite a robust process to actually officially add a disorder to this federal RUSP. Next slide. This is a bit of a busy slide and is mostly here for your future reference, but the table does serve as a reference for conditions that are currently included on the federal RUSP. And just some key takeaway messages from this table are, one is, while certainly when we are thinking of the disorders that we screen for, they are individually rare. But when we look at the birth prevalence and we take it together, it's actually quite common for us to pick up a child with one of these conditions on newborn screening. In fact, over 12,500 newborns are diagnosed in the U.S. each year with one of the conditions detected through newborn screening. The second big takeaway is that there is a range of severity of the disorders screened for by newborn screening. And programs will typically define these disorders into 2 buckets, the first being time critical and the second being time sensitive. So time-critical disorders are those that may present acutely in the immediate newborn period, and thus it's really important for us as newborn screeners to get those results out to primary care providers as soon as possible, and the national goal is to get those out within 5 days of birth. The conditions that are deemed time-sensitive tend not to present within the first week of life, and so for those, it's recommended that we try to get those results to the primary care provider within 7 days of birth. And then the third kind of takeaway and final takeaway is really in looking in that last column, is the timeline for the addition of various disorders to either the RUSP or to state screening panels. And here you can see that there is a range of dates provided for many disorders, so it's really helpful to familiarize yourself with the screening timeline for your particular state so you know what disorders your patients were and were not screened for. Next slide. Okay, so while the previous slides we really focused on the formal process of adding conditions to the RUSP, and we illustrated those conditions that are formally on the RUSP. It's really important for us to note that disorders may also be added at the state level through the legislative process. In fact, several state programs are screening for additional disorders as a result.
Dr. Rafat Ahmed from Cooper, Camden, New Jersey,
is now joining.
So several state programs are screening for additional disorders as a result of state legislative mandates. Matt, if you can click, I think there's some images that come up here. Perfect, thank you. Maybe one or two more. Oh. So typically, thank you, typically these mandates are driven by family or disease-specific advocates and often do not come with funding for the state program. So even through a legislative addition, without funding, this can really result in significant delays in implementation of the screening program for that disorder. So this may be why you may see your state screening for conditions that are not on the RUSP. That is typically as a result of a legislative mandate to screen for that disorder. Next slide. So ultimately, it's important for you as clinicians to understand that newborn screening programs remain state-based, which means that even in the context of the RUSP, state variations still exist. And so from program to program, there may be variations in a range of things. So there can be variations in what disorders the program screen for. And again, this is largely due to state-based decisions on whether to screen for disorders on the RUSP, or due to legislative mandates requiring screening for additional disorders, or due to differences in how disorders are actually added to the individual state newborn screening panel. In addition to which disorders are screened, there also may be variations in how the disorder is screened for between programs. So an example, if we look at screening, newborn screening for congenital hypothyroidism, one state program may choose to look first at thyroid stimulating hormone or TSH levels, while another state may choose to look at thyroxine or T4 levels to get at risk for congenital hypothyroidism. And actually variations in testing methodology are seen in many of the disorders on newborn screening panels. Finally, it is important to note that differences may also exist before and after screening in terms of what options are available to parents around newborn screening. So parental options may include whether or not the family has the ability to refuse screening altogether. Why is a family allowed to refuse? Some states only allow refusal for religious reasons. Others really allow refusal for any reason. There may also be options around what happens to the blood spots after screening is completed. Are they stored? Are they used? Can parents ask for them to be destroyed? So we did list several resources here that can provide you with specific information about screening practices in your state. And additional provider and family-specific resources will also be presented at the end of the presentation. Next slide. So as was mentioned earlier on, a robust newborn screening program really relies on the coordinated interactions of a host of individuals that really span a range of fields, and this is really needed in order to successfully accomplish the goals of the program. And you, as primary care provider, play a particularly pivotal role in ensuring screening results are documented, provided to, and understood by the parents in your practice. Next slide. So for the remainder of the module, we will walk through the newborn screening process in order to place your role as the primary care provider within the context of the newborn screening system. So as a reminder, newborn screening is currently composed of 3 different types of screens. The first 2 screens that we'll talk about are considered point of care screens, as the screening and the results are all available at the bedside. So newborn hearing screening uses an objective physiological test to examine the brain and ear's response to audio stimuli. So the goal of newborn hearing screening is to detect hearing loss in the range where speech is heard. What we have been seeing kind of across the country for the past few years is that approximately 1 in 300 newborns is born with a congenital hearing loss in the U.S. If we go down to pulse oximetry screening, so this screen is really aiming at detecting hypoxemia, with the idea that this hypoxemia may be indicative of a previously unrecognized critical congenital heart disease. So for this test, oxygen saturation measurements are taken after 24 hours of age in both the right hand, which we consider the preductal measurement, as well as either foot, what we consider the post-ductal measurements. Around 1 in 500 newborns is born with a critical congenital heart disease, with up to 25% of these infants being missed if relying solely on clinical symptoms or prenatal sonograms. And finally, the blood spot portion. So the blood spot portion is the oldest of the newborn screens, and again is the one that I think most physicians tend to think of when they think of newborn screening. And so this portion analyzes a small amount of blood taken from the infant's heel shortly after birth. This blood is spotted onto special filter paper and sent to a public health lab for analysis. Next slide, please. So this is a really quick schematic of the pre-analytical portion of blood spot newborn screening. So prior to collecting the blood spots, all families should be provided information about newborn screening. Ideally, this information should be provided both in the prenatal period as well as in the immediate postnatal period, and always prior to specimen collection. Nearly all state programs recommend that blood spot specimens for newborn screening be collected via heel stick between 24 to 48 hours of age. This time period enables, one, more representative analyte measurements, so kind of allows that immediate postnatal period to calm down a little bit before we grab a sample, but also allows us for that really important early detection and treatment that we need for any affected infant. After the specimen is collected, blood spots should be allowed to dry in a horizontal position for at least 3 hours prior to being sent to the public health lab. In order to facilitate efficiency in newborn screening and meet those marks of getting results out in 5 to 7 days, all specimens should be sent to the screening program within 24 hours of collection. Next slide. So blood spot specimens will be tested as soon as possible upon receipt by the screening laboratory. And there are several possible types of results that may be generated by the newborn screening program, and these are listed on this slide. For the purpose of this module, we will not review each potential result individually, as each of these results are actually discussed in more detail in future modules. Next slide. The newborn screening programs, as I mentioned before, aim to have results available within 5 to 7 days of birth. And with positive or abnormal results, we can often get those available even earlier. In the case of negative or normal results, screening programs will send the results back to the birth facility that submitted the blood spots. Some programs do also send the report to the primary care provider, whereas other programs put that expectation on the birth facility and expect that the birth facility will forward the report on. In either case, healthcare providers can also always request screening reports directly from the screening program. Positive or abnormal results are typically provided to both a primary care provider and an appropriate specialist via the telephone. Most often, the screening program relies on either the primary care provider or the specialist to notify the family, which means that the newborn screening program, we are typically not notifying the family, but relying on you or a specialist to do so. So that notification should be happening and discussing both the positive results as well as the need for further follow-up. Next slide. So without a doubt, the primary care team plays the principal role in ensuring that screening results for all patients are available and documented. So as mentioned on the previous slide, screening results, regardless of the type of result, should be available by the 2-week well-child visit and provided to the family at that visit, if not before. In many cases, you as the primary care provider will be the first person that notifies the family with a positive or abnormal result. And in the case of normal results, you may be the only way parents receive the results and have a chance to ask any questions they may have about newborn screening. Next slide. So a few key points to consider when providing newborn screening results to parents is to understand, one, they may not remember having the newborn screening done. It is done, shortly after birth in kind of the fog of delivery, and it can be difficult for parents to remember that that happened or fully appreciate what the purpose of newborn screening is. This is especially common if the first time the family was introduced to the concept of newborn screening was kind of at that 24-hour time after delivery. So because of this, many families find it helpful to receive the results along with some context. And while we will discuss communication strategies in more depth in future modules, a couple of starting points include one, reminding families about newborn screening and what newborn screening is. In other words, a screen is to identify whether the child is at risk for a defined list of treatable conditions, as well as what screening is not. In other words, it is not drug testing, it is not paternity testing. It's also really helpful to note that newborn screening only provides a risk assessment, so not a definitive diagnosis, and really does not look for all possible disorders a child might have. Next slide. This is also a really good time to talk a little bit about terminology. Hopefully, in the period of this kind of short talk, you've seen that newborn screening today involves much more than simply screening for PKU. And despite this, the term PKU test, quote unquote, is still used regularly to describe the newborn screen. And while using this term may seem perfectly benign, inappropriate terminology use has resulted in both healthcare provider and family confusion, as well as the wrong follow-up clinical evaluation and or lab tests being drawn. So you can imagine if someone says the PKU test was abnormal and you start working up for PKU only to find that the test was actually abnormal for cystic fibrosis. This can happen, we've seen it happen, and can cause a lot of confusion and inappropriate labs. So as a result of the potential for tangible negative consequences of using the term PKU test, any references to this term should be replaced with the term newborn screening, whether it's verbally, electronically in your clinic or hospital's EMR, or on paper. Next slide. So because newborn screening has been around for decades, it may be easy to dismiss it as quote unquote something that just happens, or to think, you know, I'll hear about the results if something is wrong. But the expansion and increasing complexity of newborn screening really warrants a renewed commitment to newborn screening results communication. So supporting this are results from a recent study that was done within the region that showed that almost 40% of parents surveyed reported that they never received their newborn screening results. And perhaps more telling was that nearly all parents reported that they wanted to receive their child's newborn screening results. So thus, kind of the impetus for this series, and this and subsequent models are aimed at providing guidance and information in order to meet the new challenges in newborn screening and the desires of the families that the program serves. Next slide. So to end with today's module, we have shown here several resources available to primary care providers outside, of course, of your state's newborn screening program website that have been really helpful to answer questions both on newborn screening processes as well as disorder-specific information. And I think that wraps it up, and we can open it up for questions now, I believe, Matt.
Yeah, thank you, Amy. That was a wonderful overview. I am going to go ahead and give some time for questions. I know a few of you got on a little bit after we got started, so you probably missed the announcement that I made. We internally are only able to mute you. So if you have a question or if you want to share a comment, you will have to unmute yourself. I think if you're using the computer or laptop to access the meeting, it should be relatively self-explanatory. You can click your mic. However, if you're on the phone, if you'd like to make a comment, just press *6 and that will unmute your line so that you can make a comment. And then After we have time for questions about the presentation, I would like to give our partner Kathy Cairns from the Minnesota AAP a chance to chime in. She was having a little bit of technical difficulty earlier, but I think that seems to be worked out. So Kathy, if there's more you want to add about discussion around the quality improvement, please feel free to chime in and do so as well. And Kathy, if you're trying to chime in by phone right this second, you're still muted. There you go.
Hi, this is Kathy Karen.
Hi, Kathy. Thank you.
Did you unmute everyone?
We are no. That's what we are not able to unmute. If you want to speak, you have to unmute yourself. Please feel free to do so. Again, if you're on the phone, *6 will unmute you, and if you're on the computer, you should just be able to click your mic and click the mic icon to unmute.
So I will hold off answering questions about the quality improvement module until we get questions on Amy's presentation handled first.
And Amy, maybe I can start the questions. And you mentioned the future modules would talk about the different results that might come. Can you offer us any preview about what we might hear about in those modules?
Yeah, absolutely. We can certainly entice the users. Yeah, so there will be 2 modules that talk, one about normal newborn screening results, and that may seem a bit odd to talk about communicating those results, but we have found it to be very important because there are a lot of misconceptions out there about what screening is looking for, as well as kind of what screening can't and can't do. As I mentioned when we were talking about screening tests, false positives, false negatives do exist, and it's really important for families to understand that, especially with normal results, that if their child starts presenting signs or symptoms of a condition on the newborn screening panel, just because they had a normal test does not mean they are in the clear. And that's really important for both providers actually and families. So we'll talk a little bit about that component of normal newborn screening results. And then we'll also talk about the abnormal or positive newborn screening results, kind of those so-called actionable results where we need to do something more. And what we'll talk about is taking it a little bit beyond, communicating that disorder-specific information, but also talking about how to actually have that conversation. So there have been some focus groups and surveys done with parents who have received a positive newborn screening result, and really talking about how they would like to receive it in terms of what that discussion looks like, how to present next steps, and really how to take what's a difficult situation and make it as smooth as possible.
Yeah, thanks, Amy. And the conversation around delivering positive results, or at least actionable results, we often are able to have families that have been through that get on these webinars with us. So as clinicians, if you ever wanted to be able to ask a patient a little more candidly than you might be able to as you're giving them the news, anything about that process or what they do with that information, or how it's received, it's a really nice opportunity on this call. That's the third. It'd be the third learning collaborative that we get into that. I'm certain we'll have some of our patient partners on the next call as well, but definitely for the last one. So I'm sorry, go ahead, Amy.
No, I was going to say that's a great point.
Other questions? Did you? All right. Kathy, do you want to talk about the QI aspects that people are going to need to know?
Will do. And then I will also send out to all of we've got about 54 people who've signed up for this module at this point in time. We will also accept some additional people who would like to be able to participate, especially if they're from your same practice, because you can all do the audit together. It's not work that everybody has to do separately. So more team-based participation is certainly welcomed. We have, in terms of this particular, we call it a virtual learning collaborative, over 50 participants from 11 different states, including a chunk from Minnesota, North Dakota, Michigan, Wisconsin, New Jersey, Colorado, and some other, and Iowa are the main states that are participating. The group of participants is about a third suburban practice, about a third rural practice, and about a third are urban practice. Many have electronic medical records, but we see that in this particular module, EPIC is in the minority. In our first cohort doing this module, EPIC was the electronic medical record that was used by a majority of the clinics that were participating. This time we see all sorts of different electronic medical records, and so as you look at implementing quality improvement initiatives in your practice, we may be talking in different terminology based upon the electronic medical record systems that are being used in your system. The other thing that we will be using is the American Academy of Pediatrics QIDA systems, QIDA, to be able to enter data for our audits and then to generate run charts that will be available to each practice and each clinician participating, so that you can kind of see your progress on each of the measures of this particular audit. I believe there's about 6 or 7 measures on this audit. I'll be emailing to all the participants an Excel spreadsheet which kind of shows you what the audit elements look like, along with a link to the QIDA system, so that you're able to get into that system, see the resources that are available, as well as copies of links to presentations and also some other resources that are available nationally. Additionally, we found it helpful to have a separate webinar for those that have questions on the quality improvement project that we're undertaking, so that you can ask those questions or you can listen to a webinar where other participants had asked the question. So we can leave it both ways. And then finally, if you have any additional questions, feel free to email me at any time. So we're here to help. We recognize that the reason you're taking a virtual learning collaborative is your hours don't always correspond to when you're able to participate in a group session. So this gives you the flexibility to listen to the learning presentation at the time that's convenient for you, to be able to pull your data at a time that's convenient for your practice, and also to plan your quality improvement initiatives at times that are convenient for your practice. This is beginning the second year of this particular module that has been approved by the American Board of Pediatrics. We do have some DO participants. We have been able to get this module also approved for their Board of Practice too, so that just let me know in advance so that we can help you get the paperwork for that too. Other than that, happy to answer any questions either now on the line or by email as you receive the additional information. And we've got 2 more presentations that are scheduled. We'll send out those dates along with the topics too, so that you have those available. And as we wrap up here, could you please repeat the question? Please repeat the question.
I'm not sure if a question came or not. Kathy, you dropped out for just a second.
Okay. So happy to answer any questions by email or live on the line, or if you want to call directly, be happy to answer any questions related to this particular project.
So Kathy, I have one question for you around the practices that have multiple clinicians that want to participate, especially if they haven't yet signed up. In terms of entering audits into QIDA, how does that work? Like if one practice has to have the 10 patients audited, do all participants still need to log into the system for any one given clinic, but only do 10 patients, or is one person doing that data entry sufficient? Like how does that work for folks who are multiple people at the same time?
And we do have, I think, about 3 or 4 clinics that have multiple people signed up to participate. You only need to do one audit, and you only need to really have one person enter the data for that month into the KEDA system. And that can either be a pediatrician entering it in, or if you're giving your access privileges to another staff person at the clinic. In some cases, it may be a clinic manager or a nurse that's working with you on this on quality improvement projects to enter that audit data into the KEDA system. For some that have access problems getting into KEDA, they can either email me the Excel spreadsheet of the audit data or fax it to me, and I will enter it for you. So we've got kind of 3 different ways to enter the data. But the 10 patients, the information on 10 patients in one clinic is only entered once. Even if you've got 5 different physicians participating at your clinic, you only look at the first 10 patients that come in, the first 10 newborns that come in at the beginning of the month, and then take a look at the measures that we're looking at for whether or not they had a newborn screening done. Was it documented in their record? Was it documented that the parents or guardians received the results of that newborn screening? Were there positive or borderline results? And then what was the outcome of that? Was a referral made if it was positive? So those are the measures that we will be looking at, and then looking for improvement along the way based upon what your baseline audit looks like, and then the improvement you can make over the next 2 audits. And with that, I think we've ended the session. It's 1 o'clock. I want to be respectful of your time to get back to the clinic or to the hospital. And thank you, Matt, for coordinating this audio recording, and we'll send out the link to everyone